Welcome back to the Deep Dive. This time, we're diving deep into some crucial anesthesiology topics, perfect for anyone prepping for those CPSP exams in February.
We're focusing on Anesthesia Academy's lecture series, Session 1.
It's packed with info on everything from OR safety and essential equipment to those tricky breathing systems. Ready to jump in?
Let's start with the OR, a place with, well, a lot of potential hazards.
Like an obstacle course for anesthesiologists.
Exactly. And first up, oxygen safety. We all know how important it is, but there are different types of oxygen used in the OR.
Like what?
Well, liquid oxygen is incredibly efficient for storage because it's super concentrated, but it's also extremely cold, so it needs to be handled carefully.
That makes sense.
And then there's the E-cylinder manifold system. It has automatic switchover between cylinders and a pressure relief valve. It's kind of like a backup generator for your oxygen supply.
Okay, that's good to know. We've got backup oxygen, but what about other gases?
Good point.
Like nitrous oxide for anesthesia and carbon dioxide for laparoscopic procedures?
You're right. Both have their own storage and safety considerations. Nitrous oxide is stored under high pressure, and it stays gaseous at room temperature.
Right.
Carbon dioxide, though, is stored as a liquid, and we have to be aware of its critical temperature.
Right, so we've got the gases covered, but the OR has more than just gases to worry about, right?
Of course.
What about radiation and electrical hazards? We're surrounded by all those high-tech machines.
You're thinking like a true anesthesiologist. For radiation, remember the ALARP principle?
ALARP.
As low as reasonably practicable, lead aprons, thyroid shields, and minimizing your time near the X-ray machine are key.
Right, distance is our friend. But what about all the electrical currents running through the OR? It can be a bit unnerving with all those wires and machines.
It's good to be cautious. The key is understanding the difference between microshock and macroshock.
Okay, tell me more about that.
Microshock can be deadly near the heart, even with tiny currents, while macroshock needs a much higher current to be dangerous. It's all about thresholds and where the current flows.
Microshock sounds a bit like something out of a sci-fi movie, to be honest.
It might sound futuristic, but it's a very real danger in the OR. And while we're talking about potential hazards, fire safety is another big one.
Oh, yes, fire. It does seem like a constant concern in the OR. So much oxygen and flammable stuff.
Exactly. Remember the fire triangle?
Yeah.
Fuel, oxidizer, and an ignition source. And let's face it, the OR has got plenty of all three.
That's a good point.
So it's crucial to limit oxygen delivery above 30% whenever possible. And if you do have an airway fire, remember, remove, extinguish, remove.
Remove the tube, extinguish the fire, remove the burning material. Got it. That's a lifesaver. Now let's talk about another high-tech hazard, lasers. They can be incredible tools, but also dangerous if we're not careful.
Agreed. Laser safety comes down to the right eyewear, having clear warning signs, and being aware of endotracheal tube size.
Endotracheal tube size, why does that matter?
Well, a smaller tube poses a higher risk of fire, especially when lasers are involved.
Okay, laser safety, check. But even with all these precautions, there's another factor we can't forget about. The OR environment itself.
All right.
It's more than just the equipment.
You got it. Think about things like humidity, ventilation, and noise control. They might seem basic, but they can actually have a big impact on surgical outcomes.
How so?
Well, too much humidity can lead to bacteria growth, poor ventilation traps, airborne particles, and excessive noise can make it hard for the surgical team to communicate effectively.
Wow, it's a delicate balance in there. All these environmental factors play a role in patient safety. Speaking of systems, let's dive into a big one for anesthesiologists, breathing system.
Yes, breathing systems. We've come a long way from basic insufflation to those sophisticated circle systems we use today.
And speaking of breathing systems, I have to ask about those Mapleson circuits. I keep seeing them pop up everywhere in my study materials. What's the deal with those?
Mapleson circuits are fascinating, really. They're like the ancestors of modern breathing systems. They're non-rebreathing circuits where fresh gas flow is crucial to prevent the patient from rebreathing exhaled gases.
Interesting.
The key is understanding the fresh gas inlet position, especially in those Mapleson A through D variations. It determines how effectively the circuit prevents rebreathing.
So it's all about that fresh gas flow and where it enters the system. Now, what about the reservoir bag? It seems pretty straightforward, but I bet there's more to it than meets the eye.
You're right. That seemingly simple bag does a lot. It stores gases, helps with manual ventilation, and even gives us visual cues about the patient's breathing.
Okay, that makes sense.
But here's a crucial safety tip. Always double check that the APL valve is working properly. It can stick closed sometimes, which can cause major problems.
Right, so the reservoir bag is definitely more crucial than it looks. Speaking of crucial components, let's circle back to the circle system you mentioned earlier. How does it differ from those Mapleson circuits?
Well, think of the circle system as a closed-loop recycling system for those anesthetic gases. It's definitely more complex than the Mapleson circuits, but it's incredibly efficient, especially at low gas flows.
So it's kind of like a sustainable approach to anesthesia.
Exactly. It's perfect for closed system anesthesia.
Can you break down the key components of the circle system for me?
Sure, you've got the fresh gas inlet, unidirectional valves to control the gas flow, the inspiratory and expiratory limbs for gas movement, and of course the carbon dioxide absorber, typically filled with soda lime.
Soda lime, right?
And then you have the APL valve and the reservoir bag all working together to keep things running smoothly.
It was all coming back to me now. Soda lime, pH indicators, all that good stuff. But there's one concept I'm still a bit fuzzy on. Dead space. How does that fit into the circle system puzzle?
Dead space is simply the volume in the breathing circuit that doesn't participate in gas exchange.
Okay, so it's like a no man's land for gas exchange.
Yeah, you could say that. It mainly hangs out in the Y-piece connector and anything beyond that point. And here's an interesting fact. The length of the breathing tubes doesn't affect dead space.
Huh, that's counterintuitive.
Yeah, it's not about the length of the journey, it's about where that journey ends. So the circle system is quite a well-oiled machine. And speaking of machines, let's move on to the star of the show, the anesthesia machine itself. It's a complex piece of equipment, but understanding it inside and out is essential for any anesthesiologist.
Honestly, all those knobs and gauges can be a little intimidating. Where do we even begin to unravel this mystery?
Let's start with the gas supply. It's the lifeblood of the anesthesia machine.
Right, the fuel that keeps everything running.
Exactly. It can be sourced either from a central pipeline system or from individual gas cylinders.
So it's like having a backup generator, just in case the main power goes out. What are some of the key safety features I need to keep in mind?
Safety is paramount. That's why anesthesia machines are packed with layers of protection. Pipeline inlets are color-coded and have check valves to prevent backflow.
Okay, that's a good start.
Then you've got the diameter index safety system, or DIS, which ensures you connect the right hoses to the right inlets.
DIS. That sounds pretty clever.
It is, and for cylinders, there's the hanger yoke system with the pin index safety system. It's another crucial safeguard against misconnections.
So many systems to prevent mix-ups. It's like having a built-in guardian angel for gas connections. Now, what about those gas cylinders themselves? How do they attach to the machine, and what should I know about their pressure and capacity?
Well, cylinders attach through that hanger yoke system we talked about, which uses the pin index safety system. Think of it like a lock and key mechanism, just for gases.
That's a great analogy.
As for pressure and capacity, a typical oxygen cylinder is filled to about 1900 psig and holds roughly 660 liters of oxygen.
Okay, that's a good amount of oxygen. What about nitrous oxide? Does it have a similar pressure and capacity?
Nitrous oxide's a bit different. It has a lower filling pressure, about 745 psig, but a much higher capacity, around 1590 liters.
Wow, that's a lot. Why the difference?
It's because nitrous oxide is stored as a liquid under pressure.
Ah, that explains it. So even though the pressure is lower, we can store more nitrous oxide because it's in liquid form. It's like comparing a compact car with a spacious SUV.
Exactly. Now, how do we actually keep track of the pressure inside these cylinders?
Good question. I'm assuming there's some kind of gauge or something.
Absolutely. There's the Borden pressure gauge, a handy mechanical device that gives us a visual readout of the pressure level inside the cylinder.
So it's like a speedometer for gas pressure. We can see how much fuel we have left in the tank.
Exactly. And now once we've got our gas supply figured out, we need a way to control the flow. That's where those pressure regulators come in.
Pressure regulators, those seem pretty important.
They are. They're the key to maintaining a safe and consistent gas flow to the anesthesia machine. They act like a gatekeeper, taking the high pressure from the cylinder or pipeline and stepping it down to a level that's safe for the flow meters and the rest of the machine.
So it's like a pressure reduction system,
Yeah.
ensuring a smooth and controlled flow of gas.
Precisely. And most pressure regulators work in two stages.
2 stages.
The first stage takes the high pressure and brings it down to an intermediate level.
Okay.
Then the second stage takes over, reducing it further to a level suitable for the rest of the anesthesia machine.
It's like a 2-step process for pressure reduction, making sure the gas flow is safe and controlled.
Right. And speaking of safety, let's talk about what happens if the oxygen supply fails. That's a scary thought.
That's a really important point. It could be life-threatening.
Absolutely. And that's why anesthesia machines are designed with fail-safe mechanisms to prevent hypoxia. One critical component is the pressure sensor shutoff valve, sometimes called the fail-safe valve.
What does that do?
It automatically shuts off the flow of other gases if the oxygen pressure drops too low. Basically, it prioritizes oxygen delivery above all else.
So it's like a safety net, making
Right.
sure the patient always has access to oxygen. Are there other safety features like that?
Yes, there are also various alarms to alert us to any problems. There's the oxygen failure alarm, the oxygen supply pressure alarm, and the low oxygen flow alarm.
Wow, so many alarms.
They're all there to act as our watchful guardians, letting us know immediately if anything goes wrong with the oxygen supply.
That's definitely reassuring. It's like having a whole team of safety experts working behind the scenes to ensure a constant flow of oxygen. Now, let's move on to another fascinating component of the anesthesia machine. Vaporizers.
Vaporizer.
They're like the heart of the machine, where those liquid anesthetics transform into a precise vapor for our patients to inhale.
They're where the magic happens, transforming those liquids into a carefully controlled anesthetic vapor.
I've always been curious about how they work. Can you break down the different types and how they ensure that anesthetic delivery is safe and consistent?
The most common type is the variable bypass vaporizer. Think of it like a mixing valve that splits the fresh gas flow into two streams.
Two streams.
One stream picks up anesthetic vapor as it passes through the vaporizing chamber, while the other bypasses the chamber altogether.
Okay.
By adjusting the ratio of those two streams, we can fine-tune the concentration of anesthetic being delivered.
It's like finding the perfect balance between the anesthetic vapor and the fresh gas flow. What's the advantage of using this variable bypass system?
The main advantage is its ability to compensate for changes in flow rate and ambient temperature.
So it helps maintain a consistent output of anesthetic vapor regardless of the conditions.
Exactly. It's super reliable and accurate, which is crucial for patient safety.
They sound like the workhorses of anesthetic delivery. But what about desflurane? I heard that needs a special type of vaporizer. What's so different about it?
You're right, desflurane is quite volatile, meaning it evaporates very easily. It needs a special heated vaporizer to maintain a stable temperature for precise vaporization.
It's like a high-tech oven for anesthetics. Now, you mentioned Aladdin safety and maintenance earlier. What is that exactly? Is it a special type of vaporizer or a safety protocol?
Aladdin safety and maintenance actually refers to a specific type of vaporizer designed to prevent accidents like tipping or spilling liquid anesthetic.
Spilling liquid anesthetic. That sounds disastrous.
It would be. So these Aladdin vaporizers have design features to prevent that.
Like what?
They typically have a wider base and a lower center of gravity, making them more stable, and some even have locking mechanisms to keep them securely in place.
So it's all about minimizing the risk of human error and preventing those oops moments that could have serious consequences. Now, we've covered the gas supply, the pressure regulators, and the vaporizers. What's next in our anesthesia machine tour?
Let's talk about the common gas outlet, which is where the gas mixture exits before entering the breathing circuit.
The final stop before it reaches the patient.
Right. And here's a crucial safety note. The oxygen flush valve, which delivers a high flow of pure oxygen, connects to this outlet.
Okay, so it's like a direct line for oxygen delivery.
Exactly. But we have to be extremely careful when using it because delivering that high flow oxygen straight to the patient's lungs can cause barotrauma.
So the oxygen flush valve is a powerful tool, but it needs to be used with caution.
Yes, it's like a fire hose for oxygen delivery. Now, we've traced the gas flow from the source to the common gas outlet, ready to zoom in on the final frontier, the breathing circuit.
I am. That's where everything we've talked about so far actually connects to the patient.
Exactly. The breathing circuit is the direct link between the machine and the patient. It's where those anesthetic gases, oxygen, and all our monitoring devices come together to make sure the patient is breathing safely and effectively.
Okay, let's explore those components that help ensure our patients are breathing safely and comfortably. What are the key players we need to know about?
Well, the breathing circuit has a whole bunch of components, each with a really important job. Let's start with the fresh gas flow analyzer. It's kind of like a quality control inspector, constantly monitoring what's in that gas mixture going to the patient.
So it's like having a mini lab right there in the circuit, analyzing the gases in real time.
Exactly. It uses different techniques like infrared spectroscopy or paramagnetic analysis to measure the concentrations of oxygen, nitrous oxide, CO2, and those volatile anesthetics.
It's amazing what technology can do these days. We can see exactly what our patients are breathing. But what about that heat and moisture exchange filter, the HME filter?
Ah, yes.
I know they're important for keeping the patient comfortable, but I'm not exactly sure how they work.
Well, the HME filter is like a little guardian, It's constantly working to warm and humidify those gases being inhaled.
Right.
So it helps prevent the airway from drying out, which can cause all sorts of problems.
It's like giving the patient's lungs a warm hug with every breath.
Ha! That's a good way to put it.
But how does it actually work?
It's actually pretty clever. The HME filter has a special material inside that attracts and holds onto moisture. We call it hygroscopic.
Hygroscopic, okay.
So when the patient breathes out, their warm, moist breath goes through the filter, and some of that moisture gets trapped. Then, when they breathe in, that dry gas from the machine picks up that stored moisture, warming it up and adding humidity.
So it's like recycling the patient's own breath.
Mm.
It's a very eco-friendly approach to humidity control.
Huh, I like that.
Are there any other benefits to using an HME filter besides comfort? Like, does it help prevent infections?
You're on the right track. HME filters can also trap bacteria and viruses, which helps reduce the risk of infection.
So they're like tiny little bodyguards to the lungs.
Exactly. They're working hard to keep those lungs safe and healthy. Now, we can't talk about the breathing circuit without mentioning the ventilator, that essential machine that helps our patients breathe when they can't do it on their own.
The ventilator is like a mechanical lung, stepping in to do the work of breathing when needed.
Exactly. And we need to be aware of two important things when it comes to ventilators: ventilator power and oxygen consumption.
Okay, break that down for me.
Ventilators need a power source to drive the mechanisms that create airflow. It could be oxygen or compressed air.
So it's like a car. It needs fuel to run.
You got it. And ventilators actually use up some oxygen as they operate.
Really?
It's an extra oxygen demand that we have to take into account, to make sure the patient's getting enough. Have you ever heard of circuit bellows leaks?
Circuit bellows leaks. That sounds ominous. What are they, and why should we be worried about them?
Well, a circuit bellows leak is any leak that happens in that flexible bellows part of the breathing circuit.
Okay.
They can be tricky to spot, and they can really mess up ventilation. And we could even lose those anesthetic gases, which is not good.
It's like having a hole in your breathing tube. That's definitely a problem. What are some of the consequences of those leaks? And how can we even tell if there's a leak?
Well, for starters, leaks can reduce the amount of air that actually reaches the patient's lungs, making it tougher to maintain good ventilation.
Right.
And if room air gets sucked into the circuit, it can even cause hypoxemia, which means low blood oxygen levels.
That's definitely something we want to avoid. So how do we check for leaks? Any telltale signs?
Regularly checking the circuit is crucial. You can listen for any hissing sounds or gently feel around the circuit for any escaping gas. If you find a leak, replace that part of the circuit right away.
Listen, feel, and replace. Got it. Now, shifting gears a bit, I'm curious about pressure and volume monitoring in the breathing circuit.
Monitoring is key.
It's so important for assessing how well the patient's ventilating, but I need a little refresher on the details. Can you walk me through it?
Sure. Think of pressure and volume monitoring as our window into the patient's breathing mechanics. We're watching things like peak inspiratory pressure, plateau pressure, and tidal volume to get a clear picture of what's happening.
Okay, so those are the key players, but can you break them down for me a bit further? Like, what exactly is peak inspiratory pressure telling us?
Peak inspiratory pressure, or PIP, is the highest pressure reached during inspiration.
Okay.
It basically reflects the resistance in the airways and the compliance of the lungs.
So it's a measure of how much effort it takes to get air into the lungs.
Exactly.
What can cause a high PIP? Is that always a bad sign?
A high PIP can be a red flag, indicating a potential problem.
Like what?
It could be an airway obstruction, bronchospasm, or decreased lung compliance. It's like trying to inflate a really stiff balloon.
That makes sense. So what about plateau pressure? How's that different from PIP?
Plateau pressure is measured during a brief pause at the end of inspiration when there's no gas flowing.
Okay.
It shows the pressure needed to keep the lungs inflated at a certain volume.
So it's like a measure of the resting pressure in the lungs.
You could say that. And it mainly reflects the compliance of the lungs, how easily they stretch and expand.
Right. So a high plateau pressure, could it mean the lungs aren't as stretchy as they should be?
Exactly. You might see that in conditions like pulmonary edema or ARDS. Now, you mentioned fresh gas flow contribution to tidal volume earlier. Can you explain what that means? I'm not quite sure how those two are related.
I'm a little confused about that too.
It's an important concept. Basically, the fresh gas flow, or FGF, from the anesthesia machine actually adds to the total tidal volume that's delivered to the patient, especially during mechanical ventilation.
So it's like an extra boost of air on top of what the patient is already breathing.
Precisely. And to figure out how much that FGF is contributing to the tidal volume, there's a calculation we can use.
Oh, there's math involved. Okay, walk me through it.
Well, you need to consider the FGF rate, the IE ratio, and the patient's respiratory rate.
Okay, that sounds a little complicated. Can you give me an example?
Sure, let's say our FGF rate is 6 liters per minute, the IE ratio is 1.2, and the patient is breathing at 10 breaths per minute.
But
Because our IE ratio is 1.2, inspiration makes up 1/3 of the respiratory cycle. So the FGF contribution per breath would be 6 liters per minute times 1/3 divided by 10 breaths per minute.
okay.
That gives us 200 milliliters per breath.
Wow, that's actually quite a bit. So we really need to factor in that FGF when we're assessing tidal volume, especially when we're using mechanical ventilation. Now let's switch gears for a moment and talk about compliance and compression losses.
Losses.
I've heard that these losses can affect the accuracy of our volume delivery to the patient.
You're right, they can. Circuit compliance basically refers to the stretchiness of the breathing circuit itself.
Stretchiness.
Think about trying to inflate different balloons. Some are thicker and harder to inflate, while others are thinner and easier.
I see what you mean.
A less compliant breathing circuit is like that thicker balloon. It's going to steal some of that volume we're trying to deliver.
It's like a tax on the air.
Exactly. And then you have compression losses, which happen because the gas actually gets compressed within the ventilator bellows and the circuit during inspiration.
Like squeezing a sponge and some of the water gets trapped inside.
Perfect analogy. So in a typical adult circuit at a peak pressure of 20 centimeter H2O, about 5 milliliters of tidal volume is lost to compliance, and another 3% is lost to compression.
So it's like a double whammy of volume loss.
Whoa.
What about pediatric circuits? Are those affected differently?
Pediatric circuits are usually more compliant than adult circuits, so they don't have as much compliance loss. At 10 centimeter H2O, they only lose about 2.5 milliliters of volume to compliance.
So choosing the right type of breathing circuit is really important, especially when we're working with smaller patients. Now let's shift our focus to a more serious topic. The dangers of excessive positive pressure,
That's a crucial topic.
especially when we're using mechanical ventilation,
You're right. Too much positive pressure can lead to barotrauma.
barotrauma.
It's damage to the lung tissue caused by overinflation, like blowing up a balloon until it pops.
Okay, I get it. The lungs can only handle so much pressure. What are the specific risks of barotrauma?
Well, one of the biggest risks is a pneumothorax, which is when air leaks into the space between the lung and the chest wall.
And that can cause the lung to collapse.
Exactly. And it can also cause subcutaneous emphysema, where air leaks into the tissues under the skin.
That sounds pretty serious. Are there other complications we need to watch out for? Can high pressure affect the heart too?
It can. High inspiratory pressures can lead to something called hemodynamic compromise, which basically means problems with blood circulation.
Okay.
It can decrease the amount of blood returning to the heart, which can lower cardiac output and even cause hypotension.
So it's a double whammy.
Right.
Damage to the lungs and problems with blood flow. How do we prevent these things from happening? Is careful monitoring the key?
Monitoring is essential. We need to keep a close eye on those airway pressures and adjust the ventilator settings, like tidal volume and respiratory rate, to keep those pressures in a safe range.
So it's all about finding that balance between providing enough support and avoiding excessive pressure. Now let's move on to an essential part of workplace safety: waste gas scavenging.
Scavenging is so important.
We don't want to be breathing in all those anesthetic gases all day long.
Right. Waste gas scavenging is all about protecting us and our patients from those harmful effects. It captures and removes those waste gases from the breathing circuit and the OR.
It's like a specialized ventilation system for those gases.
Mhm.
But how much exposure is too much? Are there guidelines for that?
Absolutely. NIOSH, the National Institute for Occupational Safety and Health, has some recommendations.
Okay.
They suggest a limit of 25 parts per million, or ppm, for nitrous oxide in the air.
25 ppm. Got it.
For those halogenated agents like isoflurane and sevoflurane, the limit is 2 ppm.
Okay. And what if we're using both nitrous oxide and a halogenated agent?
Then the limit for the halogenated agent actually drops to 0.5 ppm.
So it's even lower when they're used together.
Exactly. And in dental offices, where they often just use nitrous oxide, the limit is 50 ppm.
It's good that there are these specific guidelines, to keep everyone safe. Now let's zoom out a bit and talk about the operating room environment itself. It's not just about the equipment, right? The physical surroundings matter too.
You're absolutely right. The OR environment is like the stage for surgery, and creating the right environment is crucial for success.
It's like setting the stage for a performance.
Exactly. We're talking temperature, humidity, ventilation, even noise control. All of these factors contribute to patient safety and those surgical outcomes.
It's like creating the perfect microclimate for surgery. What's the ideal temperature?
Usually somewhere between 68 degrees Ver and 75 degrees air, or 20 degrees C to 24 degrees C. It's all about keeping everyone comfortable, the patient and the surgical team.
Not too hot, not too cold, just right.
Exactly.
What about humidity? Is there an optimal level for that?
Humidity control is crucial for preventing static electricity.
Static electricity. Why is that a concern in the OR?
Well, it can be a fire hazard, especially with those flammable anesthetic agents around.
Ah, I see. We don't want any sparks flying around.
Right. So typically, we aim for a relative humidity between 50% and 55%.
So it's all about finding that sweet spot where we minimize the risk of static discharge. Now, what about ventilation? Why is that so important?
Ventilation is essential for keeping the air fresh and clean. It's like the lungs of the OR. It constantly brings in fresh air and removes all those contaminants, bacteria, viruses, even those leftover anesthetic gases.
So it's all about maintaining air quality. Are there guidelines for how much ventilation we need?
The ASHRAE, the American Society of Heating, Refrigerating, and Air Conditioning Engineers, recommends at least 25 air changes per hour.
25, that's a lot of air moving around.
And ideally, that air should be HEPA filtered to remove those tiny particles that can cause problems.
That makes sense. So we've got temperature, humidity, and ventilation covered. What about noise?
Noise control is another important factor, and it's often overlooked.
Why is that?
Because clear communication among the surgical team is so important.
Right.
And all that noise can make it difficult.
It does seem like the OR can get pretty noisy.
It can. Noise levels can reach 70 to 80 decibels. That's like standing on a busy street corner.
Wow, that's loud. How can we reduce the noise?
We can all do our part by being mindful of equipment alarms, keeping our conversations at a reasonable volume, and minimizing any unnecessary movement or chatter.
So it's about being aware of our own noise contribution and trying to create a more peaceful and focused environment.
Exactly. And it's not just about the immediate situation, but also the long-term effects of noise exposure on healthcare workers.
Oh, right, like hearing damage.
Yes, chronic exposure to high noise can lead to hearing loss, stress, and fatigue.
So we need to protect ourselves.
We do. Use hearing protection when it's appropriate, and advocate for noise reduction strategies in the OR.
Right.
We need to stay healthy so we can continue caring for our patients.
It's a good reminder that we have to take care of ourselves so we can take care of others. Now, how does all of this OR environment, impact surgical outcomes? Is there a connection between a well-controlled OR and better results for patients?
Studies have actually shown that a well-controlled OR environment can significantly reduce the risk of surgical site infections.
Really? That's amazing.
It's true. Proper humidity and ventilation help to minimize those airborne contaminants, and maintaining a comfortable temperature can help reduce patient stress, both of which can contribute to better outcomes.
It's incredible how all these seemingly small details can have such a big impact on patient well-being.
It all comes back to the patient, doesn't it? Every detail, every precaution we take is ultimately about ensuring their safety and well-being.
Absolutely. It really highlights how everything we do, all these little details, come together to create the best possible environment for our patients.
It's all interconnected.
Now, speaking of protecting people, you mentioned waste gas scavenging earlier. That's obviously crucial for keeping both us and our patients safe from those anesthetic gases.
Absolutely. It's like an invisible shield protecting us from those unseen hazards in the OR.
But besides scavenging, are there other occupational hazards that anesthesiologists should be aware of?
Oh, there are definitely a few. Anesthesiology can be pretty demanding. We're exposed to radiation, needle stick injuries, and even ergonomic risks from all the awkward positions we have to get into during procedures.
It's like an occupational hazard obstacle course. What can we do to minimize those risks?
There are definitely strategies and guidelines we can follow. For radiation, it's all about time, distance, and shielding.
Time, distance, shielding, got it. Minimize our time near the source, maximize the distance from it, and use lead aprons and thyroid shields when necessary.
Exactly. Now, what about needle stick injuries? Those are always a concern.
They make me a bit squeamish, to be honest. How can
No.
we protect ourselves?
Always use those safety engineered needles and dispose of them properly in sharp containers. And never recap a needle. It's just not worth the risk.
Right, right. And always be aware of your surroundings during those procedures.
Awareness is key. Now, those ergonomic challenges you mentioned, we've all had those aches and pains after a long day in the OR. Ergonomics is all about working smarter, not harder. Pay attention to your posture, use adjustable equipment whenever you can, and take breaks to stretch and move around. Don't be a hero. Ask for help if you need to move a patient or some heavy equipment.
It's all about teamwork and pacing ourselves so we can be at our best for our patients. But with all these potential hazards, it is comforting to know that there are so many safety protocols in place to help protect us.
We have lots of safeguards in place. Organizations like the ASA, the AANA, and NIOSH are constantly working to develop and promote those best practices. They provide tons of valuable resources and guidelines to help make our work environment safer.
It's amazing to see how much effort goes into keeping anesthesiologists and our patients safe.
It really shows how seriously we take patient safety. It's always at the forefront of our minds.
Well, we've covered a lot of ground today. From oxygen safety and breathing circuits to the OR environment and occupational hazards, it's been a whirlwind tour of the world of anesthesia.
It has been a deep dive.
I feel much more confident about tackling those CPSP exams now.
That's what we like to hear.
I've gained a whole new appreciation for what goes into being an anesthesiologist. It's a challenging but incredibly rewarding field.
It certainly is.
A huge thank you to our expert for sharing your insights and expertise with us today. It's been a pleasure learning from you.
The pleasure was all mine.
And to all of you listening out there, thanks for joining us on this journey through the fascinating world of anesthesiology. We wish you the best of luck with your CPSP exams in February. Remember, you've got this. Keep studying, keep asking questions, and keep that passion for anesthesiology burning bright. Until next time, stay safe and stay curious.